Alrighty, I want to thank everybody for attending this virtual briefing on some recent Paragon Health Institute research papers. First, Follow the Money, How Tax Policy Shapes Healthcare, authored by Brian Blaze and myself, Theo Merkel. And as a bonus, Brian is going to talk about his subsequent paper, which has caused a bit of a stir lately, The Great Obamacare Enrollment Fraud. So the origins of this work started out with Brian and I ruminating on what recommendations we should have on how policymakers should think about the Affordable Care Act premium tax credit ahead of the expiration of the temporary enhancements that were created in 2021 as part of the American Rescue Plan Act. It evolved into a bit of a passion project for me. To inform our recommendations, we looked at not just the premium tax credit, but 9 other major healthcare tax provisions. And we looked not just at how each were working, but also how they came to be and how they evolved over time. And perhaps my favorite part of the paper, we provide exceptionally concisely, I may say so myself, summaries of 70 years of failed attempts at change. Finally, with those lessons hopefully learned, we have a dozen recommendations for improvement. To help guide our journey today, we have an expert hand in the subject matter, Ali Moliner, who has looked at these issues from all sorts of angles, including from a post at the Heritage Foundation, then in the US Senate as a staffer for Senator Ben Staff and Senator John Barrasso, in the House as the lead health tax staffer for the Committee of Jurisdiction, Ways and Means, for Whip, now Majority Leader Steve Scalise, and now at Melman Consulting. Also with us is Paragon's founder and president, as well as my predecessor at the National Economic Council, Brian Blaze, who has a PhD in economics from George Mason and has worked in both the Senate and the House, in addition to spearheading many of the most notable efforts to improve choice and competition in healthcare during the Trump administration. Finally, for those who do not know me, my name is Theo Merkel. I spent 10 years as a staffer in the Senate and 2 in the White House at the National Economic Council for Director Larry Kudlow. And I helped fastidiously craft this paper so that it would be easy to quickly skip around to the sections that may most interest you for those who may not have the desire to read all 75 pages. And with that, I will turn it over to Ali.
Thank you, Theo. It's really good to be here. This is one of my favorite issue areas, so I'm honored to participate, especially with the 2 of the top healthcare staffers to watch, if you guys have seen the article from today. So it's an honor. Thank you.
I missed that.
There's only a couple. You're 2 out of 5, I think. I'll send you the article. So I'm very honored to be here. I obviously love this topic and think it's incredibly important. Your guys' paper is a great tool, I think, for policymakers and staff to use as a framework to evaluate different health tax policy proposals. So I really appreciate that you wrote it. And I'm just here to keep the conversation on track and answer some questions. I'm sure many people in the audience haven't quite made their way through the 80 pages yet. So hopefully we'll get to talk about the highlights today. And with that, I'm going to get started by asking you if you can just, Theo, give a broad overview. There you lay out 6 different principles for reform. If you can talk about what those principles are and why you chose to include them, what exists in the current health tax space that made you look at these as the main pieces to consider.
Sure, thanks, Ali. And Brian, I promise that I will be concise here. But because we don't exactly know what the political circumstances will be in the future, we wanted to put forth some guiding principles for good healthcare tax policy that would be relevant no matter what the dynamics are. The first principle is quite simple, and it's, I think, much more modest than it may initially seem. Says, do not further advantage healthcare expenditures over other type of expenditures. And I mean, this basically is meant to get at the fact that tax preferences, encourage more purchases of whichever good or service that is preferenced relative to alternatives. This is going to increase spending on those goods or services, and or when supply is limited, it'll increase prices on those goods and services. So all this principle really says is healthcare already by far enjoys the most tax preferences in the U.S. tax code. It's frankly, it's not even close. And everyone complains that we spend too much in the United States on healthcare and it's too expensive. So another way to phrase this principle is the first step of getting out of a hole is to stop digging. Number two is treat direct payment for healthcare by individuals no worse than third-party payment. Insurance coverage plays an important role in mitigating financial risk, but because most of our tax preferences are for health insurance or the purchase of healthcare through your employer, most of our healthcare gets steered towards third-party payment. There are some advantages to this, such as negotiating leverage or the pooling of risks, but there's serious disadvantages too. There's added administrative costs. There's moral hazard, which basically means after you pay your premium, you have an incentive to get your money's worth. And importantly, employers and insurers will frankly have different value judgments than their enrollees, and they're too often required to make decisions on their behalf. So this brings us to number three. The price of healthcare will really only begin to reflect the value that the average American perceives it to be if it's the average American who's actually making purchasing decisions when they bear some of the financial risks. So optimally, reforms should encourage choice for individuals, not just employers or insurance companies. Not everybody's going to want this, but that is okay. We just don't want to punish those who do want to make some of their own decisions through the tax code. And once again, these are not as huge statements as some may make them out to be, because we are so far in the direction of third-party payment and limiting choices for patients that it's rather easy to come up with ways to incrementally move us in the other direction. 4 and 5 basically acknowledge that our current system provides the most benefit to those who have the highest incomes and live in the most expensive areas. Now, you may believe that tax rates are too high on those with high incomes, and that it's unfair for people to have to pay more for basic goods in super expensive metropolitan areas. That's fine, but we should debate and address those concerns outside of the realm of healthcare and not use healthcare as a platform for redistribution. And lastly, we don't suggest that any of the changes should add to the aggregate tax burden. If you have questions on how this squares with some of our recommendations for the enhanced premium tax credit, happy to tackle that in Q&A.
Thank you. Next, you said that it was a concise history. I think there's probably a few people who might differ on that point, but can you tell us, of all the things that you learned when you were researching this paper, what was the most interesting piece of health tax history?
So this is my opportunity to try to provide some encouragement to anybody that's had a good idea that is exceptionally frustrated by the lack of action. And having been a congressional staffer or an administration staffer, you often feel that way when it seems like the decks are just stacked against you. It seems like there are so many obvious policy improvements that we can make, yet few of them are adopted. And to illustrate that point, we've got a little bit of a timeline on the screen here. You know, the health savings account, which evolved as a proposal to mitigate many of the worst aspects of how we finance healthcare, it took roughly 30 years to come to fruition. The first version of this idea was concocted by staffers in the Nixon administration. This is they actually worked for what's the equivalent of CMS today, but it wasn't called CMS. It wasn't even called HICFA as it used to be. It was just a division within the Social Security Administration at that point in time. Singapore moved on the idea 20 years before the United States did. And in 1996, there's this huge inflection point in the debate. And it's happening during the debate over HIPAA, which is a major healthcare law that passes in 96. And there's actually a failed vote on an amendment in the Senate. Now, instead of tucking their tails between their legs, the advocates actually settled for a half loaf. They take a limited demonstration project that's limited to small businesses and capped participation. It's called the Archer Medical Savings Account, after the name of the chairman of Ways and Means at the time. And it takes another 7 years before HSAs become law as part of the Medicare Modernization Act and become more widely available. Yet to this day, right, we are still making recommendations on how to fully take advantage of the potential of this financing tool. So that's a way of saying if you have a really good idea, stick with it.
Well, it provides a little hope, but I will say, given that Congress hasn't been able to successfully legislate anything on HSAs in 20 years, you know, our moment is coming, maybe, I hope. But yeah, I guess it just shows how hard things
Well,
can
you
be.
have nice interludes in there when people in the administration, such as Brian and I, one of the things that we're particularly proud of was helping sort of modernize health savings accounts by allowing them to be coupled with plans that cover preventative care services pre-deductible. So there are, you know, success has many fathers, as they say. There's a lot of people that have worked on this over the years, and progress doesn't always happen all at once.
Well, and in defense of congressional staffers, the ACA put a lot of restrictions on tax advantaged accounts, and Republicans in Congress for a very long time fought very hard to roll back those tax increases, and were successful on many fronts with regard to tax advantaged accounts. So we have to tackle the most immediate problem in our defense. But anyways, moving ahead, I want to talk about the premium tax credit, because obviously we know there's a current debate going on, but I kind of want to step back and go back to when the ACA was originally being debated, and really since it has taken effect in 2014. You know, conservatives for a long time have supported individual tax credits to purchase insurance, and people who support the ACA's premium tax credit say, you know, it's a similar tax credit. So can you explain the differences between what conservatives have supported in the past and the ACA's premium tax credit?
Sure, you're certainly correct that the idea of a tax credit for health insurance goes back a long time, and there's been bipartisan support. If you look at the this is taking place during the convention for the Republican Party. If you look at the 1964 platform for the Republican Party, there is tax credits for insurance for seniors in there. There was a very large proposal that the American Medical Association spent a lot of time on in 1969, right, on tax credits. But more recently, many of the healthcare proposals by George H.W. Bush, also George Bush, a presidential candidate John McCain, a trio of GOP senators in 2014, they have tax credits, but notably they specified or suggested specifying the dollar amount for the tax credit in law, and it would be often adjusted for income or things like that. But this is where we get to a key difference with the premium tax credit. The premium tax credit is tied to the value of a benchmark plan, so the second lowest cost silver plan in a region, and then it limits an enrollee's premium contribution, who's eligible, as a percentage of their income. So why does this matter? Well, it gives insurance companies, especially in areas with limited competition, the ability to basically influence how much money they're going to be getting from the federal government by where they set the premiums. And there are also a lot of ways that states can influence how much money is flowing from the federal government. And I've got a chart here to sort of illustrate how this manifests itself. So we've got a box and whisker chart on the screen here. And what this is showing is it's showing the state premium variation or spending variation, state averages for the ACA market, which is in orange, and then you have national health expenditures for people that are on commercial insurance. And then we have the state average premium for ESI. And the blue boxes, so national health expenditures for the privately insured and for premiums for employer-sponsored insurance, they're a lot narrower, and that means they're a lot closer. There's not nearly as much variation. And then you look at the ACA, and there is enormous variation from the national average. And the real kicker here is it's not really correlated, as you can see, to significant differences in cost, in the underlying cost of care. I'll also note one last thing, which is the executive branch also gets a lot of ways that they can increase spending without any further action by Congress. We've seen a lot of this during the Biden administration with rules around benchmarks and stuff. So the point of what the proposal that we have in the paper, which is basically an incremental improvement upon the premium tax credit structure, is we suggest capping the benchmark used for determining the PTC at 125% of the national average. Now, we get into the exact reasons for that number in the paper, but essentially the idea is to allow for reasonable regional variation, but not the excessive variation that is enabled at the very least, or I think probably pushed by the current design of the premium tax credit.
So that was the structure of the original ACA premium tax credit. And a lot of that is still the same, right? It's still linked to the second lowest cost silver plan in a geographic region, but a difference with the enhanced credit is the difference in how much someone has to pay in premiums before the subsidy kicks in. Brian, can you talk to us about what the enhanced premium tax credit is and how it came about, and what
and
has
before I allow Brian to talk, I'm actually going to cut him off preemptively here because I wanted to
This is like writing a paper with him, Allie.
I want to describe this table on the screen. There was a big change that we've alluded to in 2021, which is the American Rescue Plan, ostensibly passed in response to the COVID pandemic, massively changed the tax credit in two ways. One, it reduced the amount that people had to contribute to premiums. And then two, there used to be a cap on eligibility that was at 400% of the federal poverty line, that cap was lifted. And the thing that I really want to drive home, because we looked into the evolution of how these original figures for the premium tax credit in the original ACA came to be. And the thing that I'd like to really highlight is in neither the House version nor the Senate version nor the ultimate ACA did was there any consideration to basically giving away private health insurance plans for free. So basically the enrollee's contribution would be 0% of their income. And that has created a lot of challenging dynamics. Enrollment has, not surprisingly, surged for that income category, people between 100 and 150% of poverty. And that's where I'll leave it for Brian.
Thanks, Theo, and thank you, Allie, for moderating, and thanks everyone for your participation. Reminder, if you do have questions for us to address, please use the feature on Zoom, and we'll try to get to as many of your questions as possible. You know, the first 2 years of the subsidy expansion, it was really part of the COVID relief package. And then President Biden and the Inflation Reduction Act signed the expansion of the subsidies from 2023 to 2025 has had an inflationary effect and a significant effect on the cost of the ACA. This is a pretty remarkable figure. This shows the bottom line is CBO's projection at the end of 2020 for what the premium tax credit cost would be. The top two lines, the light blue line is what CBO projected a year ago for the cost. The orange line is what CBO just released last month in its updated baseline. Two notable things about this. One, you could see the surge in subsidy spending when the enhanced subsidies are in place. So 2024, 2025, huge increase in the subsidy cost. What's really interesting about it, though, is compare these trend lines when the enhanced subsidies expire. Because remember, in the baseline, CBO scores based on the baseline, they expire starting in 2026. And you can see a huge delta between the cost of the subsidies after the enhanced subsidies expire versus what CBO projected before the enhanced subsidies were put in place. That delta over a decade is about $400 billion. And what's going on there is actions that the Biden administration took to expand the subsidies. The family glitch fix is part of it, where they based affordability off of a definition of the cost of family coverage, not self-only coverage. That expands the availability of subsidies, also encourages employers not to offer dependent coverage, which increases the cost to the government. And then something that I'm going to get into more the implications in a minute, they basically decided to stop verifying people's eligibility who reported or claimed income between 100 and 150% of the poverty line. And Allie, is it okay if I get into the great Obamacare enrollment fraud?
Yes, of course.
Okay. So this is the paper that we released about 3 weeks ago, the Great Obamacare Enrollment Fraud. And the motivation for this paper, won't get into the long story, but I was testifying in Texas, and basically Texas State Senator asked me a question that indicated there was significant gaming of income for the subsidies that was occurring in Texas. And what I did, I came back, spoke with the Paragon team, and we put some analytics to the extent of the problem. I'm going to show you some figures. I'm sorry, I don't have any box and whisker plots, but I do have some trend lines to show you what is going on. This is a figure that Paragon put out that when we put it out initially, it was wrong. And what was wrong was nothing about the data, it was the title. We initially put this figure out, and this figure, it shows the percentage of enrollment for healthcare.gov. So about 2/3 of states use healthcare.gov, which is the federal exchange. It shows the percentage of enrollment by group at the federal poverty level. So I'm probably going to use the acronym FPL. That's the federal poverty level. And you could see, so the way that we had this explained was over half of federal exchange enrollees have income between 100 and 150% of the FPL. But once we did our analysis, we were like, that is an inaccurate, a grossly inaccurate title. They do not have that income. They report that income during the sign-up process because they have significant incentives to report that income. And not only do enrollees have incentives to report this income, and I'll get into exactly the incentives in a second, but there's significant incentives for brokers to advertise free plans and to manipulate applications so that the coverage appears free. Because what we know about the ACA plans is that a lot of people won't pay any money if they have to pay their own money for ACA plans. But when the coverage was made free or the taxpayer picked up the full cost, you had a surge of enrollment that clearly benefited both brokers who had more people that they were signing up for coverage. And we have concerns that there's a lot of these rogue agents and brokers out there, as well as the insurance companies that are now getting monthly subsidy payments from the federal treasury to them. Much easier for insurers to collect money from the treasury than it is from having to serve customers. So we have the key in this chart shows after the enhanced subsidies in place, a surge in people reporting income between 100 and 150% to get the fully subsidized plans, such that more than half of all exchange enrollees in these healthcare.gov states reported that they had income between 100 and 150% of the poverty line. Now, what's the magnitude of the cost of individuals inappropriately reporting their income? So there's actually two things that occur. You have throughout the country, there's an incentive for people to underestimate their income. So this is the right side of the figure we're looking at. For households, individuals and households with income above 2 times the poverty line, they get more in advanced subsidy then they would have to pay back in a reconciliation where they have to then, where there's a process. So let me back up for a second. The subsidy for individuals is based on what they estimate their income to be for the following year when they sign up for the coverage. So for 2024, in the fall of 2023, someone's going to put what their estimated income is, or someone's going to put that in that application for that individual. And they qualify for a subsidy. That subsidy gets paid to the health insurance company that offers the plan that individual chooses. And at the end of the year, actually during tax filing season, so the spring of 2025, people know their actual income for 2024. And then there's what's called a reconciliation process, where the amount of the subsidy that was estimated is brought in line with the amount they were entitled to. Except there's significant limits on the government's ability to recoup the money if there was too much advance to the health insurance company. So this chart shows you what the financial costs to the government are of people improperly claiming income between 100 and 150% of the poverty line. So you could see above 200%, if people have incentives to underestimate income, and there's a cost for that. In non-Medicaid expansion states, there is a significant incentive for people to overestimate income because in those states, Obamacare prohibits the tax credits from being eligible for people below the poverty line. So if they estimate their income above the poverty line, they qualify for a very large tax credit and they don't have to repay any of it. So that's what you see are those 3 lines on the left. What we did in our paper is compare signups by 100 to 150 FPL with the actual people in those states that were eligible for coverage between 100 and 150% of the poverty line. And we found in 9 states, and these are the 9 states on this table, there were more people that signed up reporting income between 100 and 150% that are eligible to enroll in coverage that have income between 100 and 150% of the poverty line. You notice all of these states are healthcare.gov states. A key finding of our work is that healthcare.gov has really turned into the wild, wild west of health insurance coverage, where income isn't verified and you have a lot of fraudulent activity, a lot of really unscrupulous brokers and agents out there that are making a lot of money by manipulating and taking advantage of these fully subsidized taxpayer plans. And the decision of the Biden administration and CMS not to verify what the income is of people applying for coverage.
Well, thank you for that overview. I think obviously, as you mentioned, this is a very hot topic on the Hill these days with the enhanced premium tax credit expiring at the end of 2025. In your paper, one of the recommendations is to end the enhanced premium tax credit. I think there's going to be a lot of hurdles for Republicans to get over on this, right? I mean, you're going to have outside groups in the CBO producing premium impact and enrollment estimates that might scare some members. Do you think Republicans can overcome the enrollment and premium impact criticisms? And if so, how? And if there is a negotiation on premium tax credits, where do you see the dividing lines? Like, how would you change the credit structure if the enhanced subsidies were to continue in any form?
So I can start, and then Theo, you should jump in on that. I mean, I think there is a very strong case to be made to allow the enhanced tax credits to expire. I mean, we just presented, there's enormous amounts of fraud and waste associated with the expanded subsidies. They're also really inefficient. Like, we have done previous Paragon work that shows the cost per additional covered life is significant. Like, a lot of the subsidy expansion is just crowding out private spending with government spending. There's also one like really important effect that would happen if the enhanced subsidies are extended, which Congress should seek to avoid, and that is small employers dropping coverage. Employers with more than 50 workers are subject to the employer mandate and have significant incentives to offer coverage. Firms with less than 50, if these expanded subsidies remain in place, are going to have significant incentives to drop coverage, which really does escalate the cost of the premium tax credits going forward. And I mean, finally, I'd say again, this was supposedly a COVID relief measure, right? It's inflationary. It's given insurers lots of pricing power to set, because the structure, they can set premiums, increase premiums, and the taxpayer is the one who is on the hook for the premium increase. So I am, obviously the special interests want the money to continue. Insurance companies are going to make a hard case for these expanded subsidies to continue. But I think there's very strong policy reasons why they should end after 2025.
Yeah, the two things I'll chime in with are, one, just to reiterate Brian's point about efficiency when you're looking at CBO scores. Should keep in mind how many people are either gaining or losing coverage versus how much money is being spent. You know, we can throw an awful lot of money at insurance companies to see incremental increases in coverage, but the question is, are we getting a good return for those dollars? And then two, I think that it's particularly a bad set of incentives to have private health insurance being purchased when the enrollee does not have any financial obligation. One is obviously the implications for fraud that Brian has pointed out, but I will also note that, as a product that Brian said, like, as somebody previously only had to pay $25 for, in some cases, effectively a $500 plan in a month. And if they did not see the value in dedicating $25 to that plan, the idea that the taxpayer should step in and give it to them for free is highly questionable, but it also really removes the incentive for the insurance company to have to tailor something that creates value for that enrollee. And I think we end up in a situation more and more where basically the insurance company is not worried about creating value for the enrollees. They're just really worried about complying with insurance regulations, whatever regulations the federal government and the states put up. And that is a losing game. Look at the Medicaid program and the value that it creates for the actual enrollees. I think we'll continue to see a degradation in plan quality if that's where the majority of enrollment is.
I think that's a really good point that Theo mentions. We want people to get value out of the health insurance, and if the plans are fully subsidized, they only need to get the value that they can recoup from the cost of actually signing up for the coverage. And one thing I didn't mention about the Obamacare enrollment fraud work is our aggregate estimates of the problem. Like, this is a massive problem. We think it's 4 to 5 million people. So like 20% of all enrollees have been fraudulently enrolled. And that the cost, we think pretty conservatively, just in 2024, is about $20 billion of fraudulent subsidy spending.
Yeah, and there's a question we have, it looks like, is fraudulent income reporting fixable by administrative action if the administration were to change, or would Congress need to change statute? There is a lot of action that the Biden administration has taken to enable this by removing a lot of the program integrity measures within healthcare.gov in basically a chase for as much as enrollment as they can tout as possible. But a substantial amount of it is also enabled by people not having to pay anything for the plan.
I think your work on fraud is an important contribution to the debate. I feel like that wasn't really something that was out there prior to your paper, and will certainly play a large role as Congress has to deal with this issue, or perhaps does nothing with this issue next year. So it'll be interesting to see what role it plays in combating outside groups and the CBO's estimates on enrollment. And certainly
you asked Allie too for I think a positive, like what's something that Congress could do like affirmatively. And one of the policies that Paragon has developed and fits with the principles that Theo laid out. Like the government is going to subsidize healthcare and health insurance for lower income people. But how about we take some of that subsidy and not send it directly to health insurance companies, and send it to individuals and let them choose how to use it on the healthcare that best meets their needs. So we developed the HSA option at Paragon, and we don't have time to get into it now, but basically it would allow people who qualify for a certain Obamacare subsidy to take that subsidy and have it under their control in an HSA-like account so that they can use it on the healthcare that best meets their needs rather than sending it through the healthcare industry.
We can talk about that in the second hour of health tips. No, thank you. I want to do a hard pivot because I know that the ACA and the premium tax credit is obviously the issue of the day, but health tax is so much bigger than that, as evidenced by your guys' paper. So I want to make sure we talk about, the health tax gorilla in the room, which is the exclusion. For a long time, conservatives and Republicans have introduced various proposals to cap the exclusion. It's been a think tank idea for decades. Can you talk to me about how you view that, why you included capping the exclusion, and what you think the impact of the exclusion is on our healthcare system?
Sure. I'll take the first go, and Brian, if you could put up, I've got a chart here. So, as we note in the paper, there's a lot of downsides with the employer exclusion, regressive increases consumption on healthcare, increases consumption through third-party payment. But when you compare it to other ways to deliver healthcare and to specifically subsidize healthcare, mainly comparing it to our public programs, looks a lot less bad. So we are supporters of private insurance. We think that, in a lot of circumstances, it makes sense to get it through your employer. So we tried to come up with a proposal that, one, retained the bulk of the benefit, two, mitigated some of the excesses, and three, also learned from the criticisms of the Cadillac tax. Our proposal would cap the value of the exclusion at 125% of the national average, with an adjustment for the age of the employer's workforce. So unlike the Cadillac tax, which would have hit more and more health plans over time because it was indexed at inflation, which is slower than the growth in insurance premiums. This would inherently grow with the cost of insurance. It also provides meaningful room for regional variation and doesn't penalize employers with an older workforce. But we also were, I think, realistic. I saw some of the commentary on our paper of people that fixated on this proposal. So maybe not everybody would agree with that characterization, but we recommend that and are pretty explicit in saying that this isn't the most important thing to tackle in today's environment. We recommend that Congress should only take it on if it were doing substantial reform to our public health care programs or doing a fundamental reform of the tax code. So I'll make a parallel before I kick it over to Brian, and that parallel is the mortgage interest deduction. Members of Congress really like home ownership too, in addition to liking to provide benefits for health insurance. Yet for the most transformative tax reform in a generation, which was the 2017 Tax Cuts and Jobs Act, members were willing to reform the mortgage interest deduction. That retained a good chunk of the benefit, but frankly, it almost cut the overall value in half in a way that hit those with higher income brackets much harder than those more firmly entrenched in the middle class. And frankly, what we're proposing is much more modest than that proposal. So.
Brian, you're on mute.
Thanks. You can't do a health tax paper and not spend a lot of time writing about the exclusion. And I think the way we approached it was the best reasonable way to approach it. I mean, we understand the politics, right? The Cadillac tax was in place. I happen to think the Cadillac tax was one of the best parts of the ACA and have written about that, and was not supportive of efforts to repeal the Cadillac tax. I don't think there should be an open-ended tax preference for the exclusion. The first Wall Street Journal op-ed I wrote argued against repealing the Cadillac tax. It offered an alternative that would have favored health savings accounts and high deductible health plans. But Congress repealed the Cadillac tax in overwhelming votes, right? You've got business and labor interests in the exclusion. I think that if you do have fundamental health reform or tax reform, like this fits into what conservatives always say tax reform should be, which is about making a more efficient and productive economy, right? And that involves lowering marginal tax rates and reducing tax expenditures. So Theo's analogy of the mortgage interest deduction is, in my view, it's the best analogy. We don't think that this is something that's on the radar right now, but certainly if Congress is looking at fundamental tax reform, this should be something that is in consideration, in my view.
I think, I mean, you have to understand the exclusion and conservative criticisms of it to really properly understand like a policy position on any various health tax proposal. I mean, the main complaints with the exclusion, you don't want to replicate them when you're working on HSA policies or something like that. So I think regardless of whether or not this is the political moment, I think it's really important for people to understand why is it that Republicans and conservatives have criticized the exclusion, despite loving private insurance more than anything
Yeah,
else?
we like employer-provided health insurance, particularly self-insured employers. They have an ability to escape certain regulation and be innovative. And employees value employer-provided health insurance. And if you cap the exclusion, you're still going to have employers offering employer-provided health insurance. It may make some difference on the margin, but the overwhelming number of employers that are offering health insurance now are going to continue to offer health insurance far into the future.
I think it's a good segue into individual coverage HRAs, because I think some of the beauty of ICHRAs is that it corrects for some of the elements of the exclusion that have been criticized, right? It doesn't provide a limitless tax preference, and it doesn't lock people into employer coverage, given that the tax preference for employer coverage is so much greater than it is in any other market. So Brian, can you talk to us about ICHRAs, explain what they are, how they work, the main benefits of them?
Yeah, so this is ICHRAs were created in a rule in 2019 from the Trump administration, and it is a way for employers to provide health insurance to their workers without the employer picking the plan that works for everyone. It really is the direction of defined contribution health insurance, which has been a conservative health policy aim for decades. So the employer provides the contribution. The contribution gets the exact same tax treatment as a group health plan. So there is no distortion that the tax code has between a group plan and an individual coverage HRA. The worker then takes that and buys a plan in the individual market, and it has to be an ACA compliant plan in the individual market that works best for them. So you're significantly increasing employee choice and control over their health insurance. And for employers, I mean, a lot of employers don't want to be in the health insurance game. They want to focus on what their core business is. They don't want to have to worry about the annual renewal cycle, you know, what the premium increase is going to be. They just want to set a budget and provide that benefit to their workers. So I think it is an option that will be attractive for many employers and individuals, particularly if we can get some policy changes that improve the individual market for health insurance.
There's a future Trump administration. Do you anticipate the administration having the ability to expand HRAs beyond what they are, or do we need Congress to act here? I know that in the House they've passed a bill to codify HRAs, but you know, there's been limited uptake thus far, and I'm sure you would hope that they grow in the future. So can the administration do it, or does it have to be Congress?
Yeah, so great question. Things are always better if Congress does them, right? Because it gives the business community
Glad to
more
hear you say that from the
Well,
administration.
we'd like Congress to do some productive things in healthcare. It was with in the void that the administration had to jump in. But let me say, Congress did create HSAs. So HSAs were the qualified small employer HRAs, and that was bipartisan legislation that Congress passed in late 2016, and then President Obama signed into law. I think there are opportunities for both Congress or future administration to improve ICHRA policy. And we write about this in the paper. I think there's two main big improvements that would expand options for both employers and employees. One would be to allow employees to use the ICHRA for any plan that is available in their state. Not just ACA compliant plans. So increase options for the employee. And then for the employer, I would allow them to offer employees a choice, the group plan or the individual coverage HRA. And I suspect what would happen if that choice is allowed is that the individual market would improve, because it is people that don't have established networks or doctors, hospitals that they really have a strong preference be in their provider network, that are going to be much more amenable to the ICHRA model, at least at first. And I think expanding ICHRAs is a way to improve and make a more robust individual market for health insurance. And again, I should say one other thing. All of this stuff is voluntary. So this does not threaten the traditional group plan at all. This is all voluntary adoptions by employers. So nothing about ICHRAs changes anything about the way traditional group health insurance works.
Thank you. Well, there's only a couple minutes left, and I know we have a lot of questions. Theo wants to answer one off the top, but Brian, I want to make sure that you can look through them and see if there's any that you want to address, because we only have 6 minutes remaining, and I want to be respectful of people's time. Theo?
Sure. I just wanted to note there's several questions about price transparency, an issue near and dear to many of our hearts. And one of the main themes of multiple questions here is, well, you want people to be more active and engaged in purchasing purchasing either health insurance themselves or purchasing medical services, and that's sort of some of the underlying concept of the HSA. And don't you need price transparency for this to work? The funny thing that I find is when we were really pushing our price transparency initiatives, one of the most common pushbacks is, well, don't you need an incentive structure for this to work? So why do price transparency first? So this comes down to sort of Theo's, one of Theo's very rudimentary rules of policy, which is try to take advantage of opportunities where they present themselves. If it's a good policy, even if the circumstances around it are not perfect, you should probably try to move on it. Price transparency is something that is bipartisan, and I have totally encouraged, and the Trump administration took action on price transparency, frankly, without solving some of the underlying issues that cause many people not to shop in the first place. But frankly, those problems and the problems that we discuss in this paper are probably harder to solve, and that's not a reason to not promote price transparency. In the meantime, I wrote a paper on price transparency last year that has some recommendations for improvement, and frankly, it's great that it's bipartisan, but we need to implement the Trump price transparency rules and make sure that insurers and hospitals are being compliant with them.
Brian, are there any?
I just want to sort of make my last comment on health savings accounts, because we talked about the premium tax credits, HRAs, the exclusion in depth, and the HSA is really the gold standard here. It is the consumers. It's the account that is under the consumer's control. I love HRAs. The HRA is an employer account. And the employer sets the rules. The HSA is the vehicle that best encourages people to be cost-conscious consumers, and the amount that they save from one year gets rolled over to subsequent years. So, I mean, I think improving policy so that more Americans have access to HSAs is one of our top priorities in this area. Right now, there are limits, severe limits, and Theo talked about this a little bit with the preventative services expansion, but plans have to fit within a certain box in order to be eligible for the individual to contribute to an HSA. We think that there should be different additional plan standards for plans that can be integrated with HSAs, and that a lot of our subsidization of healthcare we should think about what we can do to reduce on the margin subsidies that go to health insurers, subsidies that are for third-party payment, with subsidies that go towards individuals, and policies that allow individuals to keep more of their own money to spend on healthcare. And expanding access to HSAs is the best way to do that.
And I will just also say that I know we didn't get to all the questions, but always feel free to reach out to us at Paragon or through our website. We're happy to talk about any and all of these offline as well.
All right, well, thank you guys so much. I think with that, we can end. I think a good way to summarize it is I think all of the different principles and HSA specifically is really about connecting consumers to their healthcare dollar, and any policy that is out there to further that, I think it fits within the theme. To kind of boil it down to it in a nutshell.
Great summary, Allie. That's why we wanted you to be here.
Thank you guys. It's been a lot of fun. Appreciate it.
Thank you, Theo. And Theo did really amazing work on this paper. It was at least 80% his effort. And if you really are interested in the history of this and how policy, a lot of policies, it takes a long time for policies to get enacted, and a lot of policy ideas never go away. I mean, I learned a lot from this paper, so I highly recommend it.
Thank you. Thanks, everybody, for their interest. Thank you, Brian, for letting me to write to my heart's extent. And thanks for joining.
Yeah, thanks everyone for joining, and thanks for the contribution to this important debate.